So welcome everybody. I am going to introduce today's speakers. So we have Beth Chichoski and Emily Finomore with us today. Beth is a clinician at Natural Resilience, where she's worked since August of 2021. Prior to that position, she's worked at several different administrative and clinical positions within WVU Medicine, including the Summit Center, Outpatient Services, Inpatient Services, and the Chestnut Ridge Adult Unit. She received her MSW from Columbia in 2000 and her bachelor's in communications from George Mason in 1998. She's a licensed independent clinical social worker in West Virginia and is certified as a hypnotherapist and clinical trauma treatment professional. And Emily Finomore is the clinical grants manager for WVU's United Summit Center, where she's worked since September 2020. Prior to that, she's worked at several different clinical therapists and management positions at WVU Medicine and in Colorado Springs, Colorado, Hamilton, Ohio, and Cincinnati, Ohio. Since July of 2020, she served on the Mon County Schools COVID Social and Emotional Wellness Reintegration Task Force and the Mon County Schools Committee of the Whole member. She received her master's in clinical mental health counseling from Wright State University in 2014 and her Bachelor of Arts in English from Wittenberg University in 2003. And she is a West Virginia licensed professional counselor. So welcome everyone. And I'm going to turn it over to Beth and Emily to start the presentation today.
Great, thanks, Mary.
Thank you. I'm going to get these slides rolling if technology is my friend today. And then Beth will go ahead and get us started.
Okay, while Emily gets the slides rolling, I'll just give everybody a little bit of background of why we're talking about this. This topic was born out of my attempts to help Emily understand what makes hypnotherapy better than EMDR. Obviously, just kidding. But it was born out of my wish to educate the larger community about the benefits of hypnotherapy, because I was a little jealous of all the attention that EMDR has been getting. Kidding, not really kidding, but that's the background. I trained and received my certification in hypnotherapy in 2005. A long time ago. Then I became a stay-at-home mom in 2007, and I did that for about 5 years. And when I moved to Morgantown and re-entered the clinical social work world, I was really disappointed that a lot of my colleagues were skeptical of hypnotherapy, didn't understand it, didn't want to understand it, and I had a difficult time explaining. I didn't really have the language to explain how beneficial it is and how it works. And at the same time, many of my therapist friends were talking about EMDR, and it sounded so similar, but again, I couldn't put my finger on like, what is it that makes it so similar? So then two things happened. I left my position with WVU Medicine and came back to private practice. And it was great for self-care, and I had more time to read. Finally, so I read some great books. I will show you Overcoming Shock by Diane Zembroff and David Hartman, who are the founders of Heart-Centered Hypnotherapy. I read Polyvagal Theory in Therapy by Deb Dana and The Body Keeps the Score. Probably you all are familiar with the last one and maybe the second one. So anyway, it finally clicked. I finally had the knowledge of why hypnotherapy and EMDR are similar, how they're different. And now I want to share this knowledge with all of you. And I asked my good friend Emily to help me explain EMDR. So with that being said, let's hit the next slide. All right. I'm going to go ahead and read straight from the slide so that I don't forget anything out of my anxiety. Both hypnotherapy and EMDR assist clients in accessing traumatic source experiences. Now, the usefulness of revisiting these experiences is in releasing repressed emotions, creating a corrective experience to change their emotional and physiological effects, and discovering the life patterns that underlie the behavioral choices. So we're using information that's congruent with the client's experience, and we assist them in reflecting on the past with an adult narrative that is about the situation rather than our distorted experience of self. This is very wordy, but we're going to break it down over the next hour. So second part that's important to understand before we get started is that the part of the brain that holds the past trauma tends to be out of our awareness. It's more difficult to access with talk therapy. But what happens is current events trigger those hidden parts to come into our awareness and disrupt our lives. And then our clients come into our office and say, I don't know what happened. I was doing so well. And then suddenly I saw a red car and I was triggered. So hypnotherapy and EMDR work within the part of the brain that holds that trauma and help to reprocess and shift the quality of the pain and the meaning of the pain from automatic negative thoughts such as I deserve to die to more positive thoughts such as I honor myself and I go forward in my life with purpose. Next slide, please. That's you, Em.
I always have to find my unmute button. So the lovely thing about Beth and I working together, we've worked together in lots of capacities over the years, is the ways that we intersect in our understanding of how we frame diagnoses in our current practice and how we kind of examine treatment modalities. So I wanted to share this slide. I would imagine a lot of you folks have already seen this one. This one's been around for a while, but really talking about window of tolerance. We're going to talk about polyvagal theory in a little bit, as that is a foundation both of EMDR and hypnotherapy, but really looking at that hyper and hypoarousal state as a really important factor of understanding how we do this initial clinical intervention. So we'll talk in further slides about kind of how we have created this foundational understanding of neuroplasticity and how we can create brain change. And that really walks the line between both of the modalities we're talking about today, as well as many other modalities, which we'll kind of discuss in parts. But really looking at this window of tolerance and how do we maintain a window of tolerance in our everyday lives, as well as then within the context of a treatment session and the treatment space. So I like to share this illustration as part of what we're going to be talking about, which is these top-down or bottom-up approaches. And then we're also looking at a bilateral approach, bilateral. And like I think was said earlier, please chime in if you guys have any questions. Feel free to use the chat, raise your hand, unmute yourself. We are happy to answer any questions as they come up for you guys. Okay, so the next slide is a very basic slide. Let's see if I can get you there. So I did want to talk about the triune brain, which I am sure you guys have heard about in different capacities. One of my favorite kind of basic brain docs is Dr. Dan Siegel, and he does a lot of work with working with parents and children, which is really kind of more my wheelhouse. We talk about kind of 3 layers to the brain, and this is again very primitive. Don't report back to the RNI about how primitive this discussion is about brain functioning. But if we think about our brain as having 3 main parts, and that the bottom parts, we really talk about our lizard brain and our wizard brain and our limbic system in between, and that's that Dan Siegel hand model. But when we talk about the communication between those parts, that's when we're talking about those intervention strategies. Are we really looking at our autonomic response system that stays down here? That's our fight, flight, freeze, fawn response, right? Are we targeting these very animalistic response systems, or are we targeting our good thinking brain? And what has to happen in order to connect those and reconnect those synapses in ways that allow us to manage our behaviors and our responses? Beth, do you want to talk a little bit about polyvagal theory here with this slide?
Yeah, I included this slide. I'm not sure how I want to segue into that. Let's just in general talk about polyvagal theory. Do you want to get that started, Emily?
Sure. So I think I alluded to this a little bit, but I think it goes without saying for me that I like to describe my theoretical orientation as really about being about neural adaptivity and not about pathology, right? When we can view our clients as adaptive, resilient humans and not as broken, damaged humans, it really forms the way we create our clinical intervention strategy and the way we help our clients narrate their own lives. And I think that that's sort of the undercurrent of a lot of these treatment modalities that really target refiring neurons and synapses, is that it's not that we're broken. It's not that we are doing something bad. It's just not working for us anymore. So what we needed in order to stay safe and protected in a time of hardship, whether that was a single incident trauma or something that occurred over a period of time, we adapted in a way to be okay. So that is the idea of neuroception. So one of my favorite writers right now, she's got a fabulous Instagram page as well. Her name is Mona de la Hook. She's out of California. She writes a lot of really great texts that are useful in different settings, working with children and young adults. Her book, one of her books is called Beyond Behaviors. But anyway, she likes to talk a lot about that it is not pathology, but faulty neuroception. So how is our neuroception getting in the way of our day-to-day functioning? And I think that that's really what we're talking about with this polyvagal ladder, is that we're really looking at how are we having these vagal nerve response systems and how are they getting in the way of the successes, right? So if I'm going about my daily activities and I'm loading my kids up in the car, and for Beth's example, a red car drives by and I'm immediately triggered into my ventral vagal state and my heart's racing and I'm sweaty and I can't focus on keeping my kids safe, I've got to do the work so I can do the things I need to do in my day-to-day activities. But 10 years ago, I needed to know where that red car was. So that was absolutely the response I needed neurologically. So when we think about all of these autonomic response systems and understanding this polyvagal kind of response, that helps to frame the understanding of our therapeutic interventions that Beth and I are talking about today. So it's staying in, like I showed you in that earlier slide, we're talking about staying in our window of tolerance. That's the most concrete way we can talk about how do we stay in this kind. When we talk about it in education, we talk about scaffolding learning and staying in that zone of learning where it's not too hard, but not too easy. In that same way, we want to be able to function day to day and intake the information we need to stay safe, to stay productive, to stay successful. So I think that's why we kind of stacked these slides one on top of the other. And so then in the next slide, does that help, Beth? Do you have anything you want to add?
Yeah, thank you. That was really helpful to segue. And so using hypnotherapy and EMDR, we help our clients understand their story, right? So the explanation that I give my clients is state, which is what's happening in your body, which is where you are along the autonomic ladder. It happens because of the story that you're telling yourself about what's going on in your environment. So for me, like the neuroception is our brain is trying to help us stay safe and tells us a story about what's safe and what's dangerous. So the red car would be, my story of a red car might be very different than Emily's story of a red car based on our experiences, right? So again, it's in that part of your brain that's harder to get to when you're doing just talk therapy. So with hypnotherapy and EMDR, we help clients understand what is the story, where did the story come from, and maybe even change the outcome of the story now, if that makes sense. If anybody needs more information or has more questions about polyvagal theory, maybe just wave. Speak now or forever hold your avocado pit. Okay. All right, sounds good, Emily, thanks.
So I love this slide because aren't those cute little neurons? But also because I think we've heard about this time and time again, that what fires together, wires together, and how crucial that is to each of us as individuals, understanding our environment and also understanding, what isn't kind of going the way we want it to. So I brought this up because Beth's talked a little bit. I put an example here of a belief. Let's say we have these neurons that have fired together and we have created this belief that I am unlovable. That is not only associated with a memory, right? We could probably pull up 25 memories of why we have that foundational negative cognition. But behind that is memories, places, emotions, people, thoughts, sensations, and situations that all kind of come in together to trigger this neuron and this firing. And when I talk to my clients, I imagine it like a rut in the road, right? So anytime any of those sensations, any of these associations are triggered, we're going to immediately go back to that I am unlovable. That could be the smell of something cooking that triggers that memory. That could be a certain season of the year. So really thinking about that wiring and firing is not only about the belief, but all of the associated experiences that could then trigger that belief to occur. Can you see the slides? Are you good?
I can see the slides. I'm just laughing at all the cute comments about the happy little neurons. And
oh, good. I can't see the comments. Keep them coming, y'all.
Michelle, my student, said she wants it on a shirt, so we need to do that.
Oh yeah, we should make some more shirts. Like my going to therapy is cool shirt. I'll probably rock that once a week. So I wanted to talk about neuroplasticity here because that is something that really crosses and intersects with both of these modalities we're talking about today, as well as a lot of the other ones that we encounter that are evidence-based best practices. Like my little picture showed you, that what fires together wires together. But what's also really powerful about that is it doesn't mean we can't get them to rewire and refire. It's easier to get them to fire the first time, so it takes, it's hard for old dogs to learn new tricks. I think that's true in our therapeutic process as well. We didn't realize all the stuff we were ingraining into ourselves when we were 7. And now here I am at 41, just chugging along, trying to heal. You use it or you lose it. So the more often that those activation points are being activated, the more quickly you're going to go to those first. And the ones that you use less, that neuronal pruning that occurs anywhere from childhood into our 20s. That pruning occurs, and then some of those responses are going to go away if we don't use them. So the other belief that we know is that you have to activate a network in order to change it. So that activation state is going to occur in both EMDR and in hypnotherapy as well, through some of our treatment modalities, and really looking at that window of tolerance as we account for activation state. So you'll see that when Beth and I both talk about our different modalities, how that network gets activated in a safe and secure way in order to be able to tolerate the treatment protocol. You have to be paying attention to the network you're in order for that neuroplasticity to be accessed. And then these are just some other facts I wanted to put in. Repetition and effort promotes brain change. So it's a state of mind, and then that changes the trait, state to trait. And brain change is active and not passive as much as we wish it were a little more passive sometimes. So the work was a little easier. Do you have anything you want to add, Beth?
No, I was thinking the state to trait reminded me when I was doing my training in hypnotherapy, it was recommended to tell your clients to say to themselves every night before they go to bed 25 times, each and every day, in every way, I'm getting better and better. And that explains why it works.
Mm-hmm. Yeah, that's really nice. So hopefully this isn't a new concept. If it is, that's okay. I really think when we talk about integration of knowledge, whether we're talking about states of change, motivational interviewing, depending on what y'all are doing for your day-to-day ins and outs, I think these clinical approaches really apply across the board, whether or not you're doing a 45-minute therapeutic hour or a 90-minute therapeutic hour. If you're doing hypnotherapy, but really looking at, are we doing a bottom-up intervention, a top-down processing intervention, or horizontal processing? So the reason I bring up these three different kind of approaches is because it really looks at all of the different states of knowledge attainment and change that we use as human beings in order to learn and integrate new knowledge. So what you'll kind of see here, I find this striking. So I work a lot with kids with complex trauma, a lot of youth who have been in foster care or adopted. And one of the first things we do with kids when they start in birth to 3 is we're going to get them into physical and occupational therapy if they're having some delays. We're going to teach them how to use their bodies, right? And we're really going to teach them their place in space. Those are bottom-up interventions. Really paying attention to sensory input. How do you experience your surroundings? Top-down processing is really prefrontal cortex heavy, right? We've got a lot of allostatic load happening, a lot that's going on here. And for some of us folks, that's really easy. For a lot of folks, it's really hard, which is why we see so much barrier to talk therapy when we're trying to treat complex PTSD and things of that nature. So it takes a lot of communication, a lot of words, a lot of thinking about thinking, right? That higher order kind of behavior that can be very challenging when we're in an activated state. And then you'll see this horizontal processing, which some people call bilat movement. There's lots of ways we kind of are starting to understand this, but really, you know, EMDR and hypnotherapy, as well as a lot of our art therapies and music therapies, do that left to right hemisphere crossing that we've found to be really effective in integrating the ways that we are frozen when we're out of that window of tolerance, right? So that horizontal processing allows us, in EMDR, what we say is you can keep one foot in the past and one foot in the present. And the reason I like to say it that way is because it feels stabilizing. We never want our folks to be so unstable that they're out of that window of tolerance. Beth, you got anything to add there?
No.
Okay, we'll get to the next slide. So this is, do you want me to play the video if I can get that going, or where do you want to start?
Yeah, just a second. So this is a clip from Office Space. I'm not sure how many of you have seen this movie. It's pretty fabulous, but also gives hypnotherapy a very bad reputation. So let's play the clip.
Emily, and Beth, we are not getting any volume on that.
That's okay. I will just go ahead and narrate what happens in the scene for those of you who haven't seen it, or maybe haven't seen it in a while. Peter gets brought to this hypnotherapist's office by his girlfriend because he's very, very stressed at work. And this therapist here on the left takes him into a trance. And while he's taking Peter into a trance, he starts to have some heart trouble, which I can identify with because I have had some like very strong heartburn while putting a client into a trance. Don't worry, everything works out in the end. But in this movie, he puts him into a trance, a very deep, deep, deep trance, which is not recommended for hypnotherapy. And I'll talk about that later. And he tells him while he's at his office, it's going to feel like he's fishing and he's not going to have a care in the world. And before the hypnotherapist can bring him out of the trance, he falls on the floor and has a cardiac event. And so for the rest of the movie, Peter is presumably still hypnotized, and he basically blows up his life and his job because he thinks he's fishing and he doesn't care about anything. That is a great movie, but it is not any way how hypnotherapy would be in the real world. So here on the left, I just listed some myths that I've heard over the years of folks not wanting to be hypnotized or not wanting hypnotherapy. They usually ask, are you going to make me cluck like a chicken? It's unnatural. That's how the devil gets in. What if I won't be able to come out of it, like Peter in the movie? like I said in the beginning, how some folks don't think that it's evidence-based or that there's anything scientific behind it. People worry that they won't be able to remember anything that's said, and that things will be said to them that they didn't want or against their will, which is also really, really concerning. So I am here to dispel those myths. Next slide. Just the facts. Okay, so hypnosis is the process of putting someone into a trance. Trance sounds scary, but it is really the simple shifting back and forth between the cerebral prefrontal cortex and the limbic system, the conscious and the subconscious mind. We do this all day long. About 80% of our day, we're going in and out of trance. Think about, you guys are watching our presentation right now, your eyes are fixed, you're in a trance. When you're driving on the highway and you're going the same route you go every day to get to Clarksburg from Morgantown, you're in a trance. How did I get here? I don't know. Your brain took over and did the work for you. Video gaming, TV, that's why advertising works. Our eyes are fixated on the screen. We're going in a trance. And now I have to save big money by shopping at Menards, right? So let's talk about ethics. As clinicians, we are all, no matter if you're a social worker or you're a counselor, psychologist, we're all bound to the ethics of clinical practice, which includes obtaining consent for treatment and agreeing to treatment goals beforehand. So when I do hypnotherapy with a client, I am getting their explicit consent to go through this process with them. And we explicitly talk about what their treatment goals are, what they want me to suggest, what they don't want me to suggest. And I would never suggest something that wasn't agreed upon beforehand. So hypnosis is a treatment intervention comprised of inducing a client into a relaxed, suggestible state called trance, and then offering post-hypnotic suggestions. So such as, let's say you wanted to stop smoking and that's all you wanted, you didn't want to do hypnotherapy. I could do hypnosis with you, get you into a trance, and I would say, every time you smell cigarette smoke, you feel nauseous. Okay, so that's hypnosis. Hypnotherapy is the process of doing psychotherapy with a client who is in a hypnotic state of consciousness. Let me check the chat box real fast and see. Okay, next slide, please. Any questions so far? All right, so history of hypnotherapy. It is one of the oldest known sciences used by the Egyptians. After the Second World War, J.G. Watkins treated what's now known as PTSD in vets with hypnosis. So what he did, he put them into a trance and he allowed the patient to regress back to the original event that was traumatizing, and the patients began to abreact, so they began to have very strong catharsis of emotions. And this allowed the symptoms to disappear and they were able to return to their normal functioning, quote unquote, health. Milton Erickson greatly advanced the use of hypnosis for therapeutic work from the 50s to the 80s. And the center that trained me, and Chris Lopez, I don't know if he's on this talk or not, it's called Heart-Centered Hypnotherapy, which was developed over 30 years ago. And they use humanistic and transpersonal psychology, also Gestalt, internal family systems, and experiential techniques. They also use neuralistic programming and behavior mod techniques to extinguish cravings, shame, fear, and to anchor the new resource state to make it easier for the client. This is very wordy. I'll talk about that in a little bit. Hypnotherapy is recognized by the American Medical Association, the American Psychological Association, the British Medical Association, and the British Psychological Association as a valid, credible, and effective treatment. And it is endorsed by the Cleveland Clinic. So to get certified, you go through 60 hours of training, 7 a.m. to 7 p.m. nonstop. That includes observed clinical practice during that 60 hours. And then in the following year, you do direct clinical practice, 20 hours with at least 10 different clients, but 20 different clients is preferred. And over the course of that year, you have monthly group supervision and individual supervision, and then you take a written exam. It's best used for many different treatments, anything you can think of, really, behavioral related. Also, it's used for a lot of medical conditions such as IBS, insomnia, pain control. I'm sure you have heard of Lamaze. That's hypnotherapy. Well, that's not hypnotherapy, that's hypnosis, but it does get the birthing mom into like a relaxed state so that her pain is lowered. Contraindications, it's not really contraindicated for folks with severe mental illness, but it makes it more difficult, because if they are actively hallucinating, if they're not really sure where the information is coming from, their own mind or outside of themselves, then it's really hard to do the work. Similarly, for folks who are in active substance use. So I usually tell folks, even if you socially drink, the 24 hours before you come in for a session, don't have that glass of wine, because we really just need your mind to be clear. All right, next slide. The process. Again, this is really wordy, so I'll try to speed it up. First, I'm going to do an interview with the client. I'm going to get an understanding of what is bringing them to see me for treatment. Usually there's a symptom and a distressing event. So I'm so angry all the time, and my husband, I can't stand him, for example. So they might say, I'm angry all the time and I don't want to be angry all the time, and I just want to have a better marriage. So that would be our goal. Then I'm going to start the induction, and induction can happen in a lot of different ways. It can look like having the client close their eyes and you do guided imagery with them while they're visualizing their favorite place. Or it can look like classic, follow my finger, follow the watch, right? With your eyes. I like to use a candle technique where I light a candle and I have the client look at the candle and then close their eyes, and then I talk them through a deep relaxation while opening and closing their eyes until they can't open their eyes anymore. Then I have them visualize a favorite, most relaxing place. And so that's really creating their resource state that they can come to anytime during the treatment. So if things get very intense and they feel like they need to go back to a safe place, they can always go back to this place in their mind, this visualized place, but also they can anchor it in their body with a physical motion of touching their thumb and forefinger together. So this is really cool, because outside of hypnotherapy, let's say they are prone to panic attacks in Walmart. And if they're just standing in Walmart and they start to feel themselves getting activated, they can do this motion, take some calm, relaxing breaths, and then they'll return to that feeling of calm. In addition to that resourcing, we do ego strengthening. So that's where I ask the client to go to a time in their life where they made a wise choice. And it might be as simple as deciding to come to therapy, or it might be something really big, like I left my abusive husband, or I went back to grad school. If the client cannot identify any time in their life where they had a wise adult self present, then I ask them to visualize or imagine bringing in a family member or a trusted friend, and they can represent that for themselves. So this is also important during the work. Should it become intense, they can call upon that wise adult to come in and provide some comfort. Then we get into the actual body of the hypnotherapy work, which is about 40 to 50 minutes. So I ask the client to get into the experience of the most recent event that was upsetting, scan their body, where is it located in your body, right? Evaluate the strength of that feeling. So, oh, I feel it in my chest, it feels heavy, and it's a 10. Okay, so then I'm going to have them express all of those feelings. Cool thing about hypnotherapy is it's very energetic. So they might yell into a pillow, they might cry, I might have them move to a kneeling position and beat on something on my couch with an energy hose. But it's really, really important to like energetically get that emotion released. Then we go back, we regress back to another time in their life where they had the same or similar feeling. We do the same process. Where's the feeling? How strong is it? Express the emotion, release it, and then we identify what conclusions did you make about yourself or about how to behave based on what happened. So for example, if I was in 8th grade and nobody talked to me because I thought they didn't talk to me because I had a weird haircut, then I made a decision to stay small and not, put myself out there. Then I don't have any friends. Hopefully that's making sense. Emily, can you hit the next slide? So we might keep going back. In one session, you could go from 46 years old back to being an infant, or you could go from 46 years old to 35. You just sort of keep going back until nothing else comes up. And once nothing else comes up and the emotions don't come up very strongly in the body, then we formally extinguish those feelings. So it kind of sounds like the desensitization process. So we would formally extinguish fear, shame, loneliness, guilt, powerlessness, and addiction. And we would energetically extinguish sadness and anger. And then we do some healing completion, which includes a lot of IFS. Then I'm doing the post-hypnotic suggestions of these are your new conclusions. These are your new decisions about how to behave. And then they have a gentle wake up, and that's pretty powerful. Any questions? Okay.
I have a question.
Yes.
Sorry, Alyssa. Hey, so when you do the induction and you bring them into that space, essentially, are you accessing like a ventral vagal space with them? Or what is that space exactly from a neurobiological perspective?
That's a great question. I would not, I guess it could be conceived of as a ventral vagal state because they're feeling safe and they're feeling connected with me as the therapist. So they're very relaxed. They feel very safe. They know they can come out of this at any time. And that's the other thing I forgot to say. You can stop at any time. And the brain also knows where it needs to go. And if it's not ready to go somewhere, then it doesn't. But to your question, Alyssa, it probably does sound like a ventral vagal state because they're feeling safe and connected. Thank you.
Yeah, thank you.
I like to leave a little pause for questions because I feel like mine always come up as soon as someone starts talking. So I wanted to just talk a little bit about EMDR and just the very basics. Please keep in mind that this takes hours, years, decades to master. So certainly this is a very broad brush stroke. So I also wanted to share with you all that the state of West Virginia has really been working to bring some evidence-based best practices into the state. As I'm sure you all know, the wait lists are just atrociously long. And so we're trying to get as many folks to want to stay and give them some free training. So actually, the state is providing EMDR training as well as CBT, DBT, TFCBT. I know there are a bunch. If any of you feel like you're not getting the notifications for when free trainings are coming about, I've got my email at the end of this slide deck. Please feel free to email me. I'm happy to help folks out in the community. And I know that, we're all in this for all the big bucks, obviously. So free training does help when you can get it. So please feel free to reach out. So there are the basics of EMDR. Is that this was originally started based on eye movement, though we use lots of different bilateral stimulation techniques that feel comfortable for the client and for the individual clinical experience. So it is not just eye movement based at this point. In fact, in my own work, I have not enjoyed using eye movement. I find it really activating and agitating. So we have tappers we can use. We can use some bilat noise sounds, and then we can also just do tapping, which is actually what we've used a lot in the telemedicine world since COVID. So we can actually do EMDR protocols with us each in our separate environments, and then we're just using kind of a butterfly hug and doing some tapping. There's also a really neat website that has created a visual bar that folks can pull up and do a share screen, and the clinician can monitor the pace of that light bar and then share that visual experience through the interwebs. So again, there's 8 phases of treatment. Those are the history and treatment planning, preparation, assessment, desensitization, installation, body scan, closure, and then the reevaluation. You kind of, on this slide, you'll see that I have broken it down into 3 separate stages. What I love about EMDR is that it's a lot of different techniques and theories combined into one. So what you'll see in these different stages is it is a 3-in-1 intervention, bottom up, top down, and then that bilat back and forth. So we're starting with stabilization. We go with the pace of the client. We're never going to move more quickly. I have experienced folks who are like, I want to get better now. Let's go, right? And the lovely thing is that this evidence-based model will really allow us to make sure that we're doing this in a safe manner and really controlling for trauma response and autonomic responses that we may not anticipate until we get into it. So you'll see in the 3 different sort of stages, the first stage is really just about case conceptualization and the planning, which Beth talked about with hypnotherapy as well. We're really creating a good treatment plan, and we're treatment planning all along the way. I can show you some documents later. We've even gone down to standardizing how we do the treatment worksheet, and that's for every session. We have in phase 3 and beyond, you'll see the access and activate all the way down. Those have a standard worksheet and workflow that we use. And what's nice about that is that that protocol can then be implemented. No matter which clinician you're seeing, you're going to get a pretty standardized level of care, and also that same or similar structure you're going to see. So if any of you have been trained in TFCBT, what I really think is TFCBT does a lot of the early legwork of EMDR. So does a lot of that cognitive work, the stabilization, that top down that we can function, and the bottom up. Learning how to access feelings, identify feelings within your body are really the first priority in any EMDR protocol and intervention. And Beth touched on this as well. And I will tell you, a lot of folks struggle to access their bodies. And so we can stay there for a long time until folks are ready to kind of move beyond that. I've worked with folks who are so frozen, they can't identify a cognitive feeling with a body sensation at all. And that's actually really typical. And so we can spend a lot of time there. And that is the gatekeeping into further work in EMDR, is that ability to not only have a cognition, but a body sensation. That's how we cross those hemispheres and really work that corpus callosum and get it growing. Our corpus callosums are known to shrink with complex trauma, and moving back and forth between our hemispheres of our brain will grow that. And then it also helps with some of that amygdalic atrophy as well. But anyway, I could talk about this stuff all day, clearly. So what I just wanted to share the basics for you, because I think it really does share a lot in common with hypnotherapy. We have a much more, I think, phased approach and a lot more parameters to the evidence-based model, which when I was a younger clinician, I hated that stuff. Like, don't tell me what to do, right? But what I love about this is as we develop our research and our evidence-based best practice, we know that no matter who you are, when you're trained in that modality, you're going to be interfacing in a very similar way and following a similar structure. Let me get to my next slide.
While you're doing that, Emily, there was a quick question in the
Oh,
chat
thanks.
asking about the recommended website with the visual bar monitor.
Oh, you guys are quizzing me. I think it's EMDR.io. Let me look it up while Beth's talking. The next time Beth starts talking, I will pull that up and I will share it in the chat. It's a free site, but
Want to pull it up now or later?
I will pull it up. I'll share it in the chat as soon as we transfer.
And there was, I know I saw Beth answered this question, but I just wanted to share it with everybody that someone asked if insurance covers these kinds of therapy, and the answer was yes.
Yes, that's a great question. So there are some insurance like some therapy interventions that insurance practices, you just have to be careful about the wording and the ways that you articulate that. I'm also trained in a modality called brain spotting, and we talk a lot about focused mindfulness. That's kind of the ways we word that in our treatment plans.
There's actually a hypnotherapy CPT code, which I was very excited about.
That is great.
Yeah, and just to make sure folks know, for hypnotherapy, the process is also incredibly phased, and you have to follow it. So it will look the same no matter what clinician is providing the treatment. What looks different is the client, right? So if someone goes to see Chris Lopez for hypnotherapy, he's following the same phased phases that I would.
So I wanted to talk a little bit about why these interventions work. I think Alyssa maybe asked some questions about like, what are we accessing? Where does that go? And I think it's such a powerful question to ask, and also really important for us in our lines of work to be able to articulate it. I often feel like in all of the clinical and social service works, we are more kind of, it's nebulous what we're doing. We know it works, we just need to be able to articulate the whys. So I think Beth talked about this a little bit earlier, but that alliance and that relationship, I know you've all seen the research that it's somewhere between like 40 and 75% of therapeutic progress is based on the therapeutic alliance, right? So that alliance is the bottom-up approach originally, reduces cortisol, reduces amygdalic state and activation state, right? All of those things are the first reason why. They're the first why, no matter which clinical intervention we're using. Working to be able to safely enter your body, increasing the activation states of new neurological patterns. That is what is allowing us to refire these synapses in a different way that allows for us to not delete the past. That's the other thing I wanted to make sure I touched on. We're not deleting anything, guys. What we're doing is decreasing activation when those memories are triggered. So it's not like the Men in Black. Do you remember when they're like, pew, and then all the memories of all the aliens were gone? That's not what's happening. And what I can tell you personally is that what happens is that we just enter a less activated state when we experience those similar circumstances. So, and again, we've talked about this before, but that decrease in the amygdalic state, decrease in activation, staying in your window of tolerance. These both work because we're working with both the body and the mind for memory reconsolidation, right? So we have to be physically activated as well as emotionally and cognitively activated in order for the refire to occur, which is why you're going to see in all of these modalities, we're talking about where do you feel that feeling, right? We're doing a level of activation, a 0 to 7. So in EMDR, we talk about a 0-7 clear. We aren't clearing things until we know that that activation state has hit as close to 0 as we can get. So, and then this slide, I put this here because it lists some of the other modalities you may be familiar with or may be trained in, and how you can integrate this knowledge into your own practice. And then using these behavioral techniques to teach self-regulation strategy, right? So we can go both bottom up and top down when necessary. Any questions? I'm looking at the time. We are short on time. I've got all of the history here of EMDR. If you'd like it, I'd be happy to talk to you individually about certification processes. We have some really great folks in town who are also doing this work. There's lots of us. We're growing in number. I mean, 7 years ago, I don't think there were 2 in Morgantown, but we've really increased. Back to just a couple of things I wanted to say. Let me see. Single incident traumas are really powerful for EMDR. They've seen in as few as 3 sessions, we can really mitigate the complex trauma response systems if we do an early interventions on those single incident traumas. So, and then the length of treatment is variable depending on the complexity of the presenting concerns. And then I did want to comment on a learning I just had the other day. So marijuana use is becoming more and more of a thing for our clients, right? And I think being able to speak to that is important. In EMDR, what we know is that if you use marijuana within 24 hours after reprocessing, it pretty much negates the entire process because it's really dulling that neurological healing process. So I share that with my clients, not so much as a judgment or a behavior change motivator, but more just so folks know what they're getting into, right? If I'm going to do all this work of a really intense EMDR session, and then I'm going to eat an edible before I go to bed, I might as well have not really done that work. And that's a waste of effort for everybody. So I do think that's just a helpful thing to share for folks as we start to see more and more marijuana in the medical community.
That is really helpful to share about the post 24 hours.
Yes.
Yeah.
And then do you want to talk about your slide for research?
Not really. We don't have to talk about research. These are just some examples of some research that I have found interesting. So those slides will be available to you all after the training. I think if we want to just go to questions and just sort of like open it up. Okay, so I did get some questions. I posted them on my Facebook and Instagram. Someone had asked, can hypnotherapy be used to prepare for something? Yes, it can. So like taking a test, like I talked about Lamaze classes, confidence before a presentation, dental anxiety, so on and so forth. Are there home programs for EMDR and hypnotherapy? Yes, as Emily had said, thanks to the advances of teletherapy, thanks to COVID, yay, we are able to do it remotely, and that's pretty amazing. This last question, I really didn't know how to answer, so I wanted to open it up to Emily. The question was, how can both therapies promote more follow-up from clients when the treatments become too painful? So the person had said when they were entering EMDR, it was hard for them to go back because it was too painful. That I haven't had that experience in my practice, so I'm going to open that up.
First of all, yeah. I think that is about really finding the right clinician that matches your need level and really about that attunement. What I would say is that good EMDR work should prep you before and after for what you can anticipate the fallout of such heavy work to be. And it is not uncommon for someone to do one very intensive EMDR session followed by a month and a half of just more talk therapy, more just kind of staying regulated and doing some of that, what do I want to say, more talk therapy sort of work. It is very common to feel exhausted when you're doing heavy work. It's a heavy lift. So I think articulating that concern and having a therapeutic space where you can articulate the labor intensiveness of the treatment is really important, and encouraging that in your therapeutic space if you're the clinician, really encouraging the feedback of what that session was like. At follow-up at the beginning of every next session, there should be a check-in about how are you feeling since your last session. And for a lot of us, that was the hardest thing I've ever done. I need to do something easy today. Can we just, chat and can I just get some day-to-day support and not do another EMDR session?
Yeah, I tend to alternate. So there's a question from Susan. Is there a recommendation, pro or con, for use of either technique with children? For hypnotherapy, it is used with children as well. I'm not aware of a specific age limit, but it can be used with children.
Yeah, I think EMDR, I really love it with kids actually, and have seen some incredible things. I like the ways it is less verbal, and it is less cognitively taxing for a lot of folks. In fact, I've seen a lot of really good work with EMDR with folks on the spectrum for that same reason. It requires a lot of body awareness, but maybe not as much social emotional awareness in ways that are taxing for some folks that we see.
We are just about at time, but I invite if anybody has any final questions for Beth or Emily. I want to thank you guys so much for this presentation. It was really terrific. A couple things. I just posted a link to our evaluation survey in the chat again, if folks want to take a minute to complete that. And as Emily and Beth mentioned, we are going to be sending out a copy of the PowerPoint, so folks will have access to that. So thank you. And just looking to see, I don't see any final questions. So thank you for joining us and for presenting. And thank you everybody for participating, and hope to see you all back at our seminars in the spring.
Thank you. Bye.